All of these TKIs inhibit BCR-ABL1 in some way, shape, or form. When BCR-ABL1 is mutated, it has uncontrolled tyrosine kinase activity leading to rapid cell proliferation. When we then inhibit that BCR-ABL1 that's been mutated, we disrupt this abnormal signaling pathways that drive CML cell proliferation and survival, ultimately leading to decreased cancer cell growth, increased apoptosis or cell death, and potentially inducing a disease remission.
You're listening to the ONS podcast, where ONS Voices Talk Cancer, a resource from the Oncology Nursing Society. Through conversations with subject matter experts, we examine the important issues in oncology nursing, from new treatments to patient-centered research to advancements in clinical practice. Join us as we hear from nurses in all facets of oncology care, from bench to bedside and everywhere in between. Hello and welcome to the ONS podcast. I'm your host, Jaime Weimer, Manager of Oncology Nursing Practice at ONS. And today we're talking with Samantha Maples, Clinical Pharmacy Specialist Supervisor for Hematology and Cellular Therapy at Allegheny Health Network in Pittsburgh, Pennsylvania, about BCR-ABL1 inhibitors. This episode is part of a series about anti-cancer drug classes, which we'll include a link to in the episode notes. As a reminder, this episode provides free NCPD contact hours. To receive credit, please review the episode notes for any guest disclosures before listening. Following the episode, complete the evaluation linked in the episode notes. Welcome and thanks so much for joining us today, Samantha.
Thanks for having me.
So to start things off, can you give us a brief overview on the history of BCR-ABL1 inhibitors in the field of oncology?
BCR-ABL1 was most commonly seen as translocation 922. It's often referred to as the Philadelphia chromosome, as it was first discovered in 1960 by Noel and Hungerford out of Philadelphia, Pennsylvania. A few years went by, of course, but finally, BCR-ABL1 was connected as the driver mutation in chronic myeloid leukemia, or CML. The landmark trial, IRIS, was a randomized controlled trial comparing interferon versus imatinib for the treatment of CML. In residency training, I was once told you can't be a card-carrying oncology pharmacist without knowing about the IRIS study, as it led to the approval of the BCR-ABL1 and tyrosine kinase inhibitor, or TKI, imatinib, for CML in 2001 and completely changed the landscape of CML treatment. Then came the second-generation BCR-ABL1 TKIs, dasatinib in 2006, quickly followed by nilotinib in 2007. Thereafter came our second-generation bosutinib and our first approved third-generation TKI, ponatinib, both in 2012, which was a huge milestone as ponatinib overcomes resistance to the T315I mutation, which no previously approved TKIs worked against. The most recent BCR-ABL1 TKI approved was asciminib in 2021, which can also overcome the T315I mutation. BCR-ABL1 can also play a role in acute lymphoblastic leukemia, or ALL. And dasatinib was approved in ALL in 2006, ponatinib in 2012, and imatinib in 2013. The other BCR-ABL1 inhibitors are not approved in ALL at this time.
Thanks so much for that overview. Certainly just an interesting history of just how important and how powerful that first drug imatinib was when it was first approved and just how sort of revolutionary it was for treating CML. So just great to hear that history. Can you talk a little bit about the mechanism of action for these BCR-ABL1 inhibitors?
All of these TKIs inhibit BCR-ABL1 in some way, shape, or form. When BCR-ABL1 is mutated, it has uncontrolled tyrosine kinase activity leading to rapid cell proliferation. When we then inhibit that BCR-ABL1 that's been mutated, we disrupt this abnormal signaling pathways that drive CML cell proliferation and survival, ultimately leading to decreased cancer cell growth, increased apoptosis or cell death, and potentially inducing a disease remission. Imatinib, nilotinib, and ponatinib more specifically bind to the inactive form of the BCR-ABL1 kinase domain, where they stabilize the enzyme in its less active state. In addition to this binding, ponatinib is a pan-BCR-ABL inhibitor that enables high-affinity binding to both the native BCR-ABL and mutated forms of the ABL kinase. This is how it's able to overcome that T315I mutation. Dasatinib and bosutinib, on the other hand, have a broader binding profile, targeting both the active and inactive conformations of BCR-ABL1 kinase domain. Since they can bind to both types of conformations, they can often overcome resistance that the other TKIs may have, with a few exceptions, of course, including the T315I mutation I keep mentioning. The newest approved TKI, asciminib, is an allosteric inhibitor that binds to a different pocket on the BCR-ABL kinase via allosteric binding to the ABL myristoyl pocket. It's what's called a STAMP inhibitor, where STAMP stands for specifically targeting the ABL myristoyl pocket. And while all the TKIs target the BCR-ABL1 binding site, they can also inhibit different off-target kinases. And these differences in off-target inhibition are responsible for some of the different toxicities we see amongst the TKIs.
So as a nurse, if I'm caring for a patient who's going to be prescribed BCR-ABL1 inhibitor, or we think they might be, is there any biomarker testing or any other testing that would be done prior to indicate eligibility or appropriateness for this type of therapy?
Any patient receiving a BCR-ABL1 inhibitor should have cytogenetic testing completing, showing a BCR-ABL1 fusion. These cytogenetic tests are commonly done in acute and chronic B-cell leukemias and can often be done separately from our larger genetic tests so that we can get these results back very quickly. Then quantitative BCR-ABL1 PCRs can be routinely monitored throughout treatment to assess disease burden and evaluate response to treatment and remission. Depending on which BCR-ABL you are prescribed, there may be other additional baseline testing completing. For example, if you are going to start on nilotinib, we would want to have a baseline EKG. In most of these, we are also can be worried about metabolic abnormalities. So we may be getting baseline lipid panels, for example, or thyroid function tests. We can also get baseline eye exams and ponatinib. So there are a few baseline patient characteristics that we may be evaluating, but most importantly, you have to have that BCR-ABL1 fusion gene before starting.
Thank you. I mean, I think that's great for all of us as nurses to know of just that testing to be aware of. And as you went into prescribing some of the other baseline testing, not necessarily biomarkers, but some of that baseline information that we need to watch for, we'll certainly, I'm sure, touch on more when we get to toxicities here just shortly. Let's talk a little bit about, you mentioned sort of different generations of these therapies. So can you talk a little bit more about, are there subclasses of the BCR-ABL1 inhibitors, and maybe highlight those examples again of kind of how those classes or those generations differ?
So there are 3 generations of traditional BCR-ABL1 TKIs. So our first generation is imatinib. It's the original BCR-ABL1 TKI. Then the second generation is nilotinib, dasatinib, and bosutinib. These are more selective than imatinib and can overcome many of the resistance mutations that are seen with imatinib. Third generation includes ponatinib alone, which is unique from all of the other generations as it is a pan-BCR-ABL TKI that can overcome the T315I mutation. This is always an exam question, at least for us pharmacists. And then we have the novel TKI, asciminib, which is not technically given a generation since its mechanism is unique compared to the first 3 generations. And for now, it stands alone in its mechanism and class.
So let's talk now a little bit about those toxicities that we've kind of hinted at. What are some of the most common toxicities and adverse events that we can expect to see with these BCR-ABL1 inhibitors? And are there any similarities or differences between those different generations?
As a class, common toxicities include nausea, vomiting, diarrhea, cardiac toxicities, including cardiac arrhythmias and congestive heart failure, metabolic abnormalities such as hypercholesterolemia and hypertriglyceridemia, nephrotoxicity, hepatic toxicity, hemorrhaging and bleeding, as well as cytopenias. Individually, some of these agents are more likely to cause certain side effects compared to others, and there are unique toxicities associated with certain TKIs. For example, imatinib can cause fluid retention, and uniquely, we can see this manifested as periorbital edema. And while it's harmless, it can really impact your patient's quality of life. It can also present as generalized edema, which is not so harmless. Imatinib can also cause heart failure and left ventricular dysfunction. Dasatinib is most commonly associated with rash, cardiac toxicities, including arrhythmias and prolonged QTc, fluid retention, which most commonly manifests as cardiac and pleural effusions and pleural hypertension. And I have seen a number of patients in practice have to stop dasatinib due to recurrent pleural effusions despite our multiple dose reductions. Nilotinib has a black box warning for QTc prolongation and sudden death. There's stringent monitoring with EKGs required, especially when starting therapy and if you're starting any other QT prolonging agents. And we also have to keep in mind our potassium and magnesium levels throughout treatment as well and make sure those are replaced appropriately. Then on the other hand, we have bosutinib. It is notorious for awful diarrhea that can happen when starting treatment. The median onset time is 2 to 4 days, so it happens really quickly and it can be severe, causing dehydration and acute kidney injury. Up to 10% of patients will experience grade 3 or higher diarrhea, which if you don't know off the top of your head, is defined as 7 or more bowel movements per day over your baseline. So this can be really impactful for patients when they're starting out. Ponatinib can also cause very serious adverse effects, which made its market approval very rocky at first. After its original approval in 2012, sales were put on hold less than a year later due to serious arterial and venous thrombotic events. This led to the FDA limiting its approved indications, adjusting the recommended dose, and revising the warnings that, in addition to updating the package insert, also included a REMS program. This REMS program was eventually removed in 2018 after updated product labeling, but the risks still remain. We can still see arterial occlusive events, as well as other cardiac toxicities, including arrhythmias, heart failure, and hypertension, venous thromboembolisms. We can also see severe neuropathies, pancreatitis, and ocular toxicity, including blindness. These effects are pretty scary, but ponatinib still serves a very important role with its activity against T315I mutations, as well as its approval in ALL. Asciminib, the newest to the market, again, has a different mechanism compared to the others, but we still have some similar overlapping side effects. It can cause hypertension, pancreatitis, and increased creatinine kinase, and it still serves as an alternative for patients with that T315I mutation if they are unable to tolerate ponatinib.
Well, thanks for sharing that very comprehensive overview. It certainly reinforces and highlights the point that I know we've made on a prior podcast where we've talked about other targeted agents where there is sometimes the assumption that, oh, these are oral agents. They can't be that bad. It's not that serious. But I think you've given us just quite a few examples of how they truly can be serious. And these side effects, these adverse events are things that we still need to be very vigilant for, not only watching for as the clinician, but also educating our patients on just the serious nature that some of these toxicities can present as if they're not managed and we're not notified as the care team, if we're not notified quickly. So let's talk a little bit about some of those toxicities that you mentioned. Are there pharmacologic strategies that can be used to either prevent or to help manage the toxicities that you discussed?
Yeah, we have a lot of pharmacologic alternatives that we can give our patients to help manage these toxicities. Some of our supportive care that we most often use is for those gastrointestinal toxicities. So we can use antiemetics such as ondansetron or chlorpromazine either before the TKI as a preventative or as needed for treatment of nausea and vomiting, as well as using loperamide if the patient is having diarrhea. And this is particularly useful for those bad offenders such as bosutinib, where we've actually in our clinic moved to using preemptive loperamide for the first 3 days of starting treatment, because it's really hard to get patients to continue to take a medication if they have such severe diarrhea that they end up in the hospital or they're unable to leave their house. A lot of times we will proactively give patients antiemetics and loperamide to help with that nausea, vomiting, and diarrhea. And then we can back off to more as an on as needed basis once they've been established on treatment. We can also use medications to help manage long-term complications that can require supportive care, such as statin therapy for high cholesterol, levothyroxine for hypothyroidism, anticoagulants for any venous thromboembolisms, and antihypertensive medications for managing any new or worsening high blood pressure.
That's really interesting. And I think an important point to remember of managing the side effects, the toxicity, is certainly important just to avoid any subsequent problems. But I think your point about making it hard for patients to continue. If right out of the gate, they suffer really horrible any toxicities, but as you mentioned, diarrhea, it's hard to convince them to keep going. I really appreciate you pointing out just the benefits of trying to prevent or to mitigate from the very beginning as much as possible, prevent those symptoms or side effects from even happening so that patients don't have to suffer and endure them. And then hopefully we can kind of rescue them from those toxicities after the fact. So proactively planning to manage those, it sounds like a great technique. Beyond the pharmacologic strategies, are there any other administration considerations that nurses should keep in mind when caring for patients who are receiving BCR-ABL1 inhibitors?
The administration practices really depend on the medication since we have a few in this class. The majority of the BCR-ABL1 inhibitors can be, and honestly, in my opinion, should be, taken with a meal. This helps reduce the incidence of nausea and vomiting. However, there's a few exceptions with nilotinib, the capsule formulation specifically, and asciminib. They should both be taken on an empty stomach. Another administration point to keep in mind is that multiple TKIs interact with acid reducers as their absorption is dependent on stomach acidity and a low pH. So when we're looking at our antacids on the market, Specifically, the proton pump inhibitors should be avoided when at all possible, as they lower the stomach acidity more than any of the others. When we're thinking about the H2RAs, such as famotidine, these should also be avoided when possible. If we're unable to avoid them, because patients can have very debilitating gastric reflux or other conditions where they need to take an H2RA. And so if they do need to take those, we recommend taking the H2RA at least 2 hours after you've taken the TKI or 10 hours before taking the TKI, so that they're at their lowest concentration when you're taking the TKI at that point. Then when we have our normal antacids or, those over-the-counter quick little Tums that patients can take, we also want to separate those by at least 2 hours from the TKI, either before or after their administration. These antacid recommendations can apply to bosutinib, dasatinib, and nilotinib.
So very important. As patients are dosing these medications for themselves at home, they're also dosing their other medications they take for other conditions or comorbidities. So providing this information and the importance of separating those types of medications, just so important for patients and their caregivers to understand. So thank you for covering that. What are some of the primary patient education points that you would recommend we communicate to our patients and their caregivers about BCR-ABL1 inhibitors?
Routine monitoring of BCR-ABL1 is important for disease assessment, so compliance with labs is necessary for prompt interventions. This is how we evaluate how their disease is responding to treatment. And we use these labs in lieu of imaging, like what we would do in something like a solid tumor, for example. And sometimes patients really don't understand the importance of the labs, especially if they've been on treatment for a while, they've been doing very well, and they don't understand the fact that this is how we're actually monitoring their disease. So really nailing that point home in the initial education is very important. Next, we want to emphasize compliance with the prescribed TKI. Chronic myeloid leukemia, again, the most common disease state we use these medications for, is a marathon, not a race. And adherence to the TKI therapy has been directly linked to better clinical outcomes, including overall survival. So the more often that these drugs are taken appropriately and correctly, the better chance that these patients are going to have improved clinical outcomes, including in prolonged overall survival. We also want to continually assess the patient's medication list. There are multiple interactions that could reduce the TKI's efficacy, which includes over-the-counter medications that patients can access without a physician approval, like the antacids we just talked about earlier. Other prescribed medications that can interact with the TKIs are the notorious CYP3A4 inhibitors and inducers, which I'm sure you've covered before, since they interact with almost every other medication out there, it feels like. Yeah. And it's an issue across the board here with the TKIs as well. So if we're stopping or starting a CYP3A4 inhibitor or inducer, we're likely going to need to adjust the TKI in some fashion. So whether that's increasing the dose or reducing the dose. And if we are missing that, this could lead to overdosing the patient and have an increased incidence of adverse effects, or underdosing the patient and leading to an increased chance of having resistance and disease progression. So in summary, our biggest upfront education points that are critical to include are lab compliance, getting the TKI refills on time to avoid any missed doses, taking the medication as prescribed, including with or without food, discussing any medication changes with your provider team prior to making them, and communicating any issues such as side effects promptly with the team, and continuing treatment throughout those side effects until we can help you manage either a dose adjustment or add additional care. Because the last thing we want to do is have a patient that is not tolerating the medication and then stopping cold turkey on their own. And then a few months later coming into the clinic and telling us, hey, I've stopped my medication. I wasn't feeling very well. What can we do now? So we want to make sure that patients always know that your door is open. You can contact our provider team and we can work as a team to really address any issues that they can have.
It's so important to just make sure patients understand who to contact and how to get in touch with them and what are the most important things for them to communicate to us in between those visits. Because as we know, it's like you said, it's a team. It's sort of a team sport when it comes to caring for patients who are exclusively on oral agents, just because we don't see them as frequently and we don't have as much sort of face time with them, especially compared to a patient who might be spending hours in an infusion versus just maybe a quick visit to the clinic for labs and seeing their provider. So how do you think pharmacists and oncology nurses can collaborate as part of that management for these patients to help them know what information they need to have their patient education provided and just serve as that trusted source of information as they encounter and manage any adverse events or toxicities?
Depending on the clinic and setting, there's going to be significant collaboration between nursing and pharmacy to confirm that these patients receive the ongoing information needed to be successful with BCR-ABL1 TKI treatment, from, like you said, identifying drug interactions, monitoring adherence and lab compliance, and managing these toxicities. A lot of that information is going to be obtained by the nurses directly, at least in our clinic where I practice. We have a very structured oral anti-cancer therapy monitoring program where we have dedicated nurses that complete comprehensive toxicity assessments and evaluate lab compliance with each refill that our clinic sends. Our clinical pharmacists also then perform a clinical review with each refill, reviewing the toxicity assessments collected by the nurse, any lab results, any changes in the medication list, clinic notes, and information there otherwise collected by those nurses. And at that point, the pharmacists and nurses can work together to discuss what's going on with the patient currently and make any recommendations for additional management strategies for the best outcomes, whether that's evaluating compliance and how to improve compliance, how to mitigate these drug-drug interactions or manage these toxicities with supportive care or TKI adjustments, with then, of course, the blessing with the provider.
Samantha, what do you see as the future for these BCR-ABL1 inhibitors? Are there clinical trials ongoing, or do you see them becoming more widely used in the future?
We are continually seeing these agents expand their indications to different lines of therapy, as well as more TKIs being approved for acute lymphoblastic leukemia. For example, asciminib just got approved in the frontline setting within the last year, whereas previously it was only approved in relapse refractory setting. Also, last year, imatinib was the first BCR-ABL1 TKI to come out with a commercially supplied suspension option as well, which is huge in the pediatric space and also our adult patients who are unable to swallow tablets for other clinical reasons. So I really hope the other BCR-ABLs do follow suit and we have more commercially available suspensions. I also anticipate resistance to continue being an issue and newer TKIs to come to the market to address various resistance mechanisms and have different toxicity profiles to those that are already approved. For example, I anticipate more allosteric BCR-ABL1 inhibitor approvals similar to asciminib. And then there are some other types of BCR-ABL1 inhibitors in the pipeline, including RNA interface-based therapies, which target BCR-ABL1 gene expression and could also mitigate resistance that we see with the BCR-ABL TKIs.
Well, Samantha, thank you so much for joining us on the podcast today. A lot of great information about a very important drug class, especially some of the earlier agents that first came on the market. It's just great to hear how that history has evolved and just how important they have remained in the care of patients. As we reach the end of our podcast, we like to always just run through a kind of a series of quick fire questions to help summarize some of the points that we've talked about today. So to start that off, how do you think healthcare professionals can evaluate maybe their hidden bias or sort of assumptions they might have about BCR-ABL1 inhibitors?
What I've seen is that since the second generation and subsequent TKIs have been approved, imatinib has really fallen out of favor for first-line treatment due to the deeper and longer responses seen with the newer TKIs. Sometimes, though, imatinib may be the better option due to specific toxicities of other TKIs that might not be in the best interest of the patient, especially if they have certain comorbidities or if cost is an issue. Imatinib may also be the better choice in that instance. And again, if they are unable to swallow, now imatinib also has a suspension option. If a patient is elderly and they're diagnosed with imatinib, it may still be wise to choose imatinib as a frontline therapy, even if you don't get as quite a deep or long of a response, and it really shouldn't be completely rolled out up front. Additionally, a lot of providers will choose one second-generation TKI as their go-to, and it may not be the best fit for each patient. So really critically evaluating prescribing patterns and evaluating adverse effects and risk versus benefit for each patient is very vital in this patient population. And we really shouldn't jump to be using things just because they're new and shiny in the frontline setting. Even if it gets approved in a certain setting, that doesn't really mean we should maybe be sequencing that way. Because like I mentioned earlier, a lot of times CML does end up being a chronic disease that patients can be on treatment for a very long period. So if you start with your top runner at the very beginning, sometimes you can burn an option that you may have benefited from saving for later.
What are some common misconceptions about BCR-ABL1 inhibitors?
You already mentioned one that I wanted to mention, which is that just because it's a little pill doesn't mean that it's benign. They can have very big consequences, but they're also very powerful for treating the disease. So it is a bit of a win-lose. So yes, they work very well, but also we need to be cognizant of what we're prescribing, how to handle those toxicities, and what to expect. But another big misconception regarding the BCR-ABL1 TKI treatment is that it's always going to be a, quote, forever treatment. That used to be the thought when it came to CML treatment specifically, that newer data has come out to suggest that this may not be required for every patient. There is more information being published on the safe discontinuation of these medications with treatment-free remissions. And it's coming out every year with more and more information about who would be eligible and who can have the option to stop these treatments instead of having a lifelong chronic condition requiring continuous treatment. And we're seeing more patients in clinical practice be able to stop BCR-ABL1 treatment, which has been a great development in CML.
That's really amazing and good to know that they're thinking about that and trying to find those opportunities for when it's for the right patient to be able to give them that break from therapy. What is something about this topic that's not often discussed, but you wish people knew more about?
I'm not sure if it's not often discussed, but people who don't work in healthcare may not be aware. And if they do not have conditions like this, they may not be aware of just how huge a barrier cost of treatment can be. So these treatments can be so expensive, and the majority of patients are still going to have to take these continuously. And as we mentioned earlier, compliance is huge. So missing doses can really impact the patient's clinical overall outcomes, including overall survival. And while some patients can stop, most will not be able to. I've seen patients with copays of up to $3,000 a month, which is really not sustainable for the average American. And we are finally seeing some generic versions of these medications come out, but the financial toxicity to patients and institutions is significant, and it needs to be addressed at a systemic level. If patients are having difficulty, though, there are assistance programs and copay cards out there that are available for certain TKIs, and we may be able to switch patients to a different TKIs and investigate an alternative treatment if cost is a barrier to adherence, since we know that is a link to overall survival, but sometimes that's not possible. And so I really wish we would continue to have the conversation surrounding the cost of healthcare in the United States.
What additional training or education do you think oncology nurses need to stay current on this topic?
I would encourage them to continually look for new approvals in CML and to watch the continuing educations that come out in different platforms, especially when it comes to treatment discontinuation, as that is a hot topic right now. And different patients are eligible for that, and some will never be eligible. So I do think it's important to stay on top of that so you're not misleading patients and saying you may be able to stop this at some point if they don't meet that eligibility criteria. And I do anticipate that to change over time. So I would encourage them to stay on top of the data that is coming out in that area.
And then finally, do you have any recommendations for additional resources that maybe patients or other providers could use to learn more?
The National Comprehensive Cancer Network, or NCCN, has really stepped their game up in outlining the differences between these TKIs with administration practices and adverse effects, as well as monitoring recommendations within their chronic myeloleukemia guidelines. It is very clear on when to draw BCR-ABL1 levels and what we should be seeing at certain time points for optimal responses, including when to consider changing therapies to an alternative TKI. There's also a significant amount of guidance available on what we currently know about who is eligible for treatment-free remission trials and how and when to restart therapy if indicated. This information didn't used to be so readily available. You would have to really dig through individual articles and package inserts to compare the side effects and the resistance patterns of the different BCR-ABL1 TKIs. But now NCCN has really put together a very comprehensive guide for practitioners. And then they also have patient education references as well.
Outstanding. Well, Samantha, thank you again for joining us today on the podcast. It's been great talking with you and learning so much that I did not know before about BCR-ABL1 inhibitors. Do you have any final comments to share with our listeners today?
I think we covered the majority of things about BCR-ABL1 inhibitors. I just want to say thank you for having me on the podcast today.
Thanks for joining us. Thank you for listening to the ONS podcast. Tell us about your favorite part in this episode by leaving a review wherever you download your podcast. For more resources and information about oncology nursing, visit us at ons.org and ons.org/voice. The ideas and opinions shared in this episode represent those of the guest and not necessarily ONS.